Okay, there we go. So, contraindications to dialysis in the ICU, I would say there are very few absolute contraindications to dialysis because dialysis can be life-saving. But there are some, I guess, relative or practical contraindications that we should consider, especially when choosing the dialysis modality. So sometimes we do intermittent hemodialysis, sometimes we do what's called slow, low efficiency dialysis, or continuous renal replacement therapies. And this depends often on the patient's hemodynamic stability and clinical context. So here's a way to think about it. Contraindications, absolute contraindications are rare, but it might be that you are unable to obtain IV access for dialysis in a patient. And sometimes you may rely on like a surgical or interventional radiologist to help you with this IV access. But if you cannot get good vascular access, then it would not be possible to do that type of dialysis in the intensive care unit. And you would have to evaluate that patient for the appropriateness of doing, for example, peritoneal dialysis. Can you see my slides?
We
Yes.
only we see the slide with contraindications to dialysis in the
Perfect.
ICU.
Okay. Just want to make sure. Okay. So now, since we know there are very few absolute indications or contraindications, we can talk about some of the relative contraindications, which are really just considerations when you are evaluating a patient for dialysis. So oftentimes in our critically ill patients, they have hemodynamic instability. And when you start intermittent hemodialysis or even continuous renal replacement therapy, hypotension can become a problem. And sometimes that is refractory to vasopressors and inotropes. So we may actually have to really slow down the rate at which we dialyze our patients. So we may consider the continuous forms or the slow, low efficiency dialysis. Patients that have severe coagulopathies and a high bleeding risk will also potentially have those worsened by going on dialysis. Dialysis circuits are typically require anticoagulation such as heparin or citrate. So when your patient has a bleeding risk, you might want to consider the risks versus the benefits of starting them on dialysis. Some of the things that we can do for those patients is to use regional citrate anticoagulation or heparin-free circuits. In resource-constrained settings or overwhelmed ICUs, the availability of these machines, trained staff, and replacement fluids may actually limit how feasible it is for us to do dialysis or CRT. Okay, so the next question is, in chronic kidney disease patients, are there ways of identifying acute kidney injury before onset of oliguria, serum urea or serum creatinine rise? So are there other things that we can see that that might give us some indication? And I'll give you about 30 seconds to answer that question as well. And then Dr. Arkin and Tet, do you see any good answers coming in through the chat box?
Still waiting.
Okay.
Anemia.
Anemia. Yeah.
Okay. Oh, that's interesting. Yeah. So I think we'll go ahead and dive into the discussion here, but this is a really important area for ICU patients and critically ill patients, and including the perioperative setting. Patients with chronic kidney disease are already at very high risk of developing acute kidney injury. But serum creatinine and urine output are kind of later markers. So we often rely on clinical, physiologic, biochemical, and novel biomarkers to detect kidney injury early before oliguria or before the lab changes. So some of the clinical risk stratification is useful. So if you can look at your patients and understand the risk for acute kidney injury, then you can start to manage the patient in a way that will decrease the risk of having an acute exacerbation or acute kidney injury on top of their chronic disease. So patients with chronic disease are already at a baseline reduced glomerular filtration rate. So even small additional insults can tip them over into acute kidney injury. So things like hypotension or certain medications, sepsis or septic shock, specifically medications, I think of contrast or non-steroidal anti-inflammatories and aminoglycoside antibiotics. Decompensated heart failure or liver disease are also clinical situations that might tip someone with chronic kidney disease over into the acute kidney injury. There are a lot of different risk scores. There's not one that stands out to me more than the others, but you can look at some of the clinical scoring systems to determine how at risk your patient is for acute kidney injury. I think before you have oliguria and serum creatinine rise, you need to look at your hemodynamics and physiologic parameters. So making sure that you have good urine output and maintain that urine output. If you start to see your urine output trends go down, that might be an early indication even before oliguria. Some people will use urine sodium, the fractional excretion of sodium, the fractional excretion of urea that can detect some of the pre-renal physiology. And especially in chronic kidney disease, this can be a little bit more difficult to interpret. So oliguria is actually defined as less than 0.5 milliliters per kilogram per hour of urine output. So I'm quite particular when I'm attending in the intensive care unit. I insist that my trainees and students report the urine output of their patients in those using those units, how many milliliters per kilogram per hour, because that gives us an idea based on that patient's specific body weight of where they are in relation to oliguria. There are other very sophisticated biomarkers that can be used and are available in some settings. They're not really something that we use even in our very high resource setting at Stanford, so I won't go into those too much. You can also look at volume status using point of care ultrasound. So that might be helpful to determine if you have a pre-renal state, or even looking at the kidneys themselves to see if there's any sort of obstruction that might be like a post-renal cause that would tip your chronic kidney disease patient into acute kidney injury. Just wondering from the other panelists, is there anything else that you look at that might make you think about acute kidney injury and a chronic kidney disease injury patient? I don't know if Dr. Kimani's here or Dr. Ted or Arkin. Anything else I missed?
I agree with you. I think, identifying AKI before the lab values rise is an art, so to speak, and factoring in a lot of patients' factors. Some people put in their comments about positive fluid balance despite oral intake and urine output. So those are good things to monitor besides just relying on the lab values.
Right. Great. Thank you. Anybody else?
I think about the etiology. So if I have a patient in 3 or 4 pressor shock, I'm anticipating that there's going to be an AKI while I'm supporting the patient. And so even when I'm waiting for the oliguria or I'm waiting for the creatinine rise, just seeing how unstable the patient is, I already have it filed away that this is a patient who's going to be very high risk for a significant AKI or maybe even needing hemodialysis.
Great. Thank you both so much. Yeah. So I think in summary, the chronic kidney disease patient is already at very high risk. And so sometimes relying on oliguria and serum creatinine rise alone is a little bit late. So looking at clinical risk stratification, physiologic monitoring, considering your POCUS, if you have those novel biomarkers, which we don't actually use very commonly, you can consider those. But just really taking great care of that patient early and making sure that they have good hydration and stable hemodynamics, and you avoid the nephrotoxic agents is really, really the key takeaways. Okay, let's give you 30 seconds to answer this. What are the predisposing risk factors for renal disease in the ICU? So what happens in the ICU that makes these patients at higher risk? Any good answers in the chat?
Sepsis, hypotension, shock, dehydration.
Perfect. Perfect. Good, 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 good. Okay. So it's important for us to understand the predisposing risk factors for renal disease, because if we understand what the risk factors are, we can mitigate those risks for our ICU patients. So the baseline patient-related factors, do they have chronic kidney disease? We've already mentioned that. Then do they have proteinuria, albuminuria? Are they elderly or the older patients? There are certainly comorbidities or other diseases that can make kidney dysfunction more likely, such as diabetes and heart failure. We talked about liver disease already. Similarly, peripheral vascular disease can also include renovascular disease, which might make it more common for these patients to get into trouble. And then we've started to talk about medications. So certain medications, we consider them what we call nephrotoxic, and they stress the kidney function quite a bit, and can push them into some dysfunction. We talked about non-steroidal anti-inflammatories. We've talked about some of the antibiotics. Additionally, ACE inhibitors and angiotensin receptor blockers in the acute kidney injury phase can also be problematic. They blunt some of the compensatory mechanisms, such as prostaglandins and angiotensin-mediated autoregulation of the afferent and efferent limbs of the glomerulus. So these medications are really contraindicated, or at least relatively contraindicated in the acute renal failure setting, which is very common in our ICU patients. And then we mentioned volume status. You really need to make sure that volume status is adequate. Some of the other kind of ICU related acute risk factors in critical illness, again, we've talked about sepsis, septic shock. You guys put that in your chat, which is great. The use of vasopressors needs to be balanced with fluid resuscitation so that you're not what we say squeezing an empty tank. We talked about contrast. Sometimes big surgeries and fluid shifts can also lead to some acute kidney injury. Mechanical ventilation. So maybe I could ask my co-panelists, what about the use of high PEEP? Does that have any effect on the kidneys in positive pressure ventilation?
I think in theory, if you have high PEEP, you're going to have maybe venous congestion that backs up. But I would say that in reality, optimizing oxygenation and ventilation is going to be better for the kidneys than worrying too much about the PEEP.
Okay, spoken like a true intensivist. So oftentimes what's good for one organ may not be the best for the other. We often have challenges managing what's best for the kidneys, what's best for the heart, what's best for the lungs, what's best for the brain. So that was a very intensivist answer. Thank you. Other things that happen to critically ill patients, you mentioned, Dr. Arkin, venous congestion. Rhabdomyolysis and hemolysis are also things that can worsen kidney function. And then later in this FAQ, we're going to get into some of the oncologic emergencies. So those are also things we'll talk about in regards to renal function. So our key takeaways for AKI in the ICU, it's usually not due to just one thing. A lot of our patients already have underlying kidney disease, or they're elderly or diabetic. They are exposed to multiple insults or hits, such as hypotension, sepsis, venous congestion, nephrotoxins. So it's really important for us to recognize those risk factors and take the best care of our patients and mitigate those factors as are able. Any other points I missed from the other panelists?
You covered it all, and people mentioned in the chat about myoclonus and rhabdo,
Okay, yeah, good, wonderful.
contrast is brought up as well, the use of IV contrast.
Yeah, yes. Okay, good. So it sounds like we're all on the same page here. Do any of my other panelists want to tackle this question, which is which diuretic is preferred for patients with renal disease? I don't know if either of you want to. If not, I can certainly keep going.
I'm happy to.
Thank you.
Maybe let's wait a few minutes for people to respond.
Absolutely.
Yeah, I see a lot of people responding about loop diuretic, furosemide, Lasix. Torsemide is mentioned, metolazone is mentioned too. So the loop diuretics are actually preferred in moderate to severe renal disease. And in the US we call it Lasix, but generic name will be furosemide. But other agents like bumetanide, torsemide has longer half-life and better bioavailability orally, but they are all in the same category of loop diuretic. So the reason they are preferred is their site of action. They work on the thick ascending limb of the loop of Henle. And so that area remains effective even in reduced GFR state. So patients' potency remains good, and is capable of producing a brisk diuresis, essential for managing volume overload in patients with renal injury. So the dose adjustment might be needed for these patients is, if the patients have kidney injury, you may need to give a higher dose than routine dose. There's also a ceiling effect. So meaning like after a certain dose, you're not getting as much urine output as you desire. So escalating doses beyond the ceiling effect yields diminishing returns. So, you might have noticed this already in practice. For all these patients, you want to monitor electrolytes, volume status, and one common thing about Lasix is ototoxicity at high doses, especially if patients are also getting aminoglycoside. So that's one category. Another category is thiazide.
Before we move on to thiazides,
Yeah.
Dr. Ted, I just want to say and get your opinion, but I think a lot of us who work in the intensive care unit have been in the situation where we've given what we think is a generous dose of a loop diuretic, of furosemide, and then we have our nephrologist consult and our renal doctor friends come in and they give like twice the dose that maybe someone else started with. So it's often a higher dose, as you mentioned, than some people will give initially.
That's totally true. Nephrologists have given Lasix as high as like 250 milligram, and I was so gentle with starting 40 milligram of furosemide. So I think I feel like I've started doing higher doses in settings where I'm deciding whether someone is going to respond or not respond, as going on dialysis, not dialysis. Then I ended up reaching for like high dose just to get my decision point made about, are they going to respond or not respond? Then I will adjust the doses later.
Yeah, same.
Yeah. So moving on to another category is thiazide or thiazide-like diuretic. So it's preferred in mild renal disease or as an add-on. The thing about thiazide is it acts on the distal convoluted tubules of the kidney, so it's less potent than loop diuretic. So in mild CKD or mild AKI cases, thiazide remain effective even for blood pressure control and mild diuresis. But in severe CKD, you might want to combine that with a loop diuretic for real effect on diuresis. And one clinical pearl is metolazone 30 to 60 minutes before the loop diuretic. They combine together, they enhance the effect of diuresis. In all these diuretic agents, you want to monitor the patient for hyponatremia, hypokalemia, and volume depletion. And often patients are also become magnesium depleted as well too. So another category is potassium sparing diuretic, like spironolactone, eplerenone, amiloride, or triamterene. I would say these agents have limited role in significant renal disease, and they're not often like first line for volume control in moderate to severe renal impairment. Another problem with these agents is because they are potassium sparing, so they have a high chance of causing hyperkalemia, hypotassium in CKD or AKI, especially patients are taking ACE inhibitors or ARBs, like angiotensin receptor blocker agents. So, but these agents are amazing for patients with heart failure. So spironolactone is often recommended medications in patients with heart failure with reduced EF or even preserve EF, but you want to be cautious and monitor the potassium closely.
One of the situations in which I think about potassium a lot is in the acidotic patient, because in acidosis, often the potassium will go up because it shifts out of the cells. So I certainly try to avoid potassium sparing diuretics in that situation. Is that also part of your practice, Dr. Tut?
Yeah, so acidosis, patients who could be acidotic, even if respiratory or metabolic from any other mean, as the kidney changes the acid ion with potassium, so you will have hyperkalemia. So like if the patients are also on any other potassium sparing diuretic, potassium can go up beyond what you anticipate. So I think it's good to be cautious with potassium sparing diuretic in sick ICU patients.
Perfect.
And another thing to be considered to think about is in patients with acute pulmonary edema in CKD. So if we have patients who have volume overloaded situation in the chest, so high dose Lasix, high dose loop diuretics are first line, but you may add on like metolazone if patients are still not peeing much. If patients have hypertension in CKD, but they're not volume overloaded, just so you're managing like blood pressure, so thiazide-like diuretic, it's often a good choice. If patients are diuretic resistant, so meaning you've given like a high dose of your diuretic, what's the next step? Dr. Crawford, do you have any tips and tricks when patients become diuretic resistant?
Well, you already mentioned adding metolazone to loop diuretics. Sometimes we'll use continuous infusions. So instead of giving, a BID or twice daily dosing, we'll actually just start an infusion of a loop diuretic and titrate that up to the urine output that you desire. Some of the other things is we've already mentioned, like avoiding NSAIDs or nephrotoxic agents. Making sure you have enough blood pressure to perfuse the kidneys is another thing that I think about. Did I miss anything?
No, I think we covered it all.
Great. Okay, so that was a lot about diuretics. Maybe we can just summarize with some key takeaways that Dr. Tett shared with us. So loop diuretics are the preferred agent for patients that have moderate to severe renal disease. So we typically use furosemide, and that's actually the same medication that I've seen in some resource constrained settings. So hopefully everyone on the call has access to a loop diuretic. And this is really good for volume control, even at a low GFR. The thiazide or thiazide-like diuretics are useful in mild chronic kidney disease as adjuncts in resistant cases. And the potassium-sparing diuretics can be used, but must be tied to close monitoring of potassium and should probably be avoided if you have a patient that has a high level of potassium. Thanks so much, Dr. Tett. It looks like you're going to start us off on this next section too. So we're going to move on from renal diseases in critically ill patients and talk a little bit about in-hospital arrest and ACLS. This is not a review of the algorithms involved in ACLS, but more about in-hospital arrest and how to really have optimize your outcomes when you have someone who has an in-hospital arrest. So with that, I'll turn it over to you with the first question.
So what do you prioritize doing ACLS, airway management or chest compressions, and why? Maybe I'll take a few minutes for
Yeah.
everyone to respond.
Again, these questions are directly from you, the learners and participants in this series. So I actually picked the ones that I thought were really great or the ones that were asked frequently. So this is definitely one of them that was mentioned a lot by a lot of the learners. Maybe about 20 more seconds and then we'll give you the answers. Okay, Dr. Tech, I think that's good.
So, yeah, so people were responding like chest compression first. Some people do respond airway. So the new ACLS guideline, the top priority is high quality chest compression. Airway management has become the second phase. The reason is chest compressions maintain vital organ perfusion. So in cardiac arrest, the way to maintain the organ perfusion is by doing really good high quality chest compression. High quality meaning you want to do compression at a rate of 100 to 120 per minute. You want to push on the chest and making sure that you are pushing at least like 5 to 6 centimeter depth and allowing for a full recoil. And that is associated with better survival and better neurologic outcomes. And even if you have interruption in compression, it can reduce the coronary perfusion pressure. So, the time that we take to intubate the patient, and if you are the solo provider, any time away from chest compression will end up accumulating in reducing coronary perfusion and worsen outcomes. So
Can I
yeah.
Can I ask you, Dr. Tet, a little bit about what happens during the compression and what happens during the recoil and why that's so important not to interrupt that sequence of compression and recoil?
Yeah, so doing the recoil, this is the phase where coronary perfusion happens. So your coronary arteries are perfused during the chest recoil. So there is a higher chance of obtaining ROS, return of spontaneous circulation, if you continue to perform high quality CPR. So, and another thing that, the reason airway becomes a second thought process, second priority is doing this chest compression, and there is maybe passive, patients are getting passive ventilation a little. So passive oxygenation, patients can be provided via a non-rebreather or back mask ventilation without an advanced airway. That should also work. So the new 2020 AHA-ACLS guideline recommended starting chest compression immediately and delaying advanced airway placement until after initial cycles, unless there's a primary airway cause. So meaning if you are the solo provider, I would prioritize chest compression and passive oxygenation via a non-rebreather mask, or if there's another provider to provide like bagging the patient. So that
Do you
would be
ever use, if you don't have someone there with you with a bag and a mask or like a second provider, or you can't find a non-rebreather mask, would you use nasal cannula or high flow oxygen or something like that, or just skip the
anything,
oxygen?
whatever available oxygen resource you have. If you
Just
don't
skip the
have
oxygen.
passive oxygenation while you're doing prioritizing the chest compression.
Great.
And another issue, the reason the airway becomes the second priority is prioritizing the airway too early often leads to harmful interruption. I talked about how the chest compression and the recoil, how important that is. And so moving on to the next slide.
Yeah, thank you so much. Those are such good explanations. And oh, I'm so glad we have a summary to go back over it and
Yeah.
the important things.
So in summary, the priority doing ACLS is start high quality chest compression and early defibrillations if indicated. Also, if you have Zoll's monitor or any other monitor to evaluate the rhythm, and if the patients are having VFib or VTach, that should be a priority, early defibrillation. Airway management comes second, especially only after chest compression. And the rationale is continuous perfusion is life-saving, and airway intervention support oxygenation, but can passively be given and can be delayed for the first few minutes in most cases.
So we're talking about seconds and minutes. We're not talking about hours without ventilation. Just the first few minutes, the compressions are most important. Is that correct?
That's correct.
Okay, this is a perfect next question because we're often taught ABCs in management of acute decompensation of patients, but sometimes we talk about CAB. So which approach is correct and why?
Maybe let's take 20 seconds for people to respond.
Perfect. Ten more seconds. Okay, great.
So good answer. A lot of people answer, and the answer is CAB, and some answer ABC. So the traditional approach has been ABC, airway first. And the reason that happened way back was historically many arrests were thought to be due to respiratory in origin, especially in kids. So establishing airway came first. But the new and as well as the modern standard, as well as the current standard that's evidence-based is CAB, circulation comes first. So you should do chest compression first because it's prioritized perfusion of the heart and the brain. And as I discussed in my previous slide, and airway, obtaining airway comes after circulation. So delays in advanced airway also leads to minimum interruption. And the breathing, which is ventilation, so provide ventilation after airways open. And here's where you can do bag mask ventilation or advanced airway placement. So that comes much later. So the new priority is CAB. The reason is improve survival, reduce the delay in providing chest compression, and it matches the real world physiology. So in cardiac arrest, the immediate problem is lack of blood flow, not lack of oxygen in the lungs. So that's the new AHA guidelines since 2010, and is reaffirmed in every 5 years updates.
I'd like to point out one area of nuance, if I may. We are talking about cardiac arrest. And so in cardiac arrest, you want to prioritize circulation, then airway and breathing. However, the ABCDE approach is still appropriate on initial assessment of a patient who is in distress. So, for example, Dr. Tett, you're an emergency medicine physician and you walk into the room for the first time. You're still going to see if the patient is breathing and if their airway is open. Like, for example, if they're talking to you, you know their airway is open and you know that they're breathing. But if they're not, then you would also move also to assessing circulation. Do they have a pulse? Are they conscious, et cetera? And so when we go, for example, respond to an emergency on the wards or in the PACU or recovery room, or even in the emergency department, the way we approach an initial assessment might still be A, B, C, D, E. Would you say that that's correct?
That's correct. So CAB approaches for patients who are in cardiac arrest, so meaning like no pulse, not breathing. So, but if patients are alert, awake, talking in any other situation, I will still see how can they talk? That's an airway assessment. And also it's like a nice gesture to say hi and see if they respond first.
Oh, don't forget our manners. That's right. Okay, so maybe we could summarize quickly the CAB one more time.
Yeah, so circulation first, airway and breathing is the current resuscitation sequence because early perfusion saves lives and ventilation can safely follow without compromising outcomes.
And particularly that coronary perfusion you mentioned. Great.
Yeah.
Okay, so now we know we need to do high quality CPR, but what does that actually mean? What is high quality CPR?
So maybe let's take like 10 seconds for people to respond.
Perfect. Thank you.
Yeah, so the high quality CPR, there are some key elements. Number one is adequate compression rate. So the target is 100 to 120 compressions per minute. So I remember the sound, I might be old school now, but staying in life, So that tune gets around.
I didn't know you had singing talent too, Dr. Tut. You have all kinds of talents.
That tune gets around like 100 compressions per minute. So if it is too slow, you have inadequate perfusion. If it is too fast, you are leading to incomplete recoil and reduced filling. And another issue is number two is adequate compression depth. Make sure that you are compressing patients adequately. So in grown-up patients, at least like 5 centimeter of chest compression, but not more than 6 centimeter. In kids, you want to gauge based on whether kids are infants or children. So infants only need about 1.5 inches or like 4 centimeter, and children, it will be about 5 centimeter. The third important issue is you want to make sure that the full chest recoil, so meaning allowing chest to recoil, like come back to back to your hand, and don't lean on the chest. The reason recoil is important is it allows and permits venous return back to the heart, so maximizing stroke volume for the next chest compression. And the fourth thing is minimize interruption. And I think in real life, like the chest compressions get interrupted so many times by everything. So ideally, you want to make sure that there's one person who's dedicated to do chest compression at all time, who's not interrupted with other tasks. So the goal is you want to have at least 80% of chest compression at all time. So meaning like someone should be on the chest 80% of the time doing cardiac arrest. And any pauses that if you are pausing for a rhythm check, it should be less than 10 seconds. So every interruption lowers the perfusion pressure and delays the return of spontaneous circulation.
If we think about it, there's a lot of other things going on. Someone may be trying to start an IV, somebody may be trying to start an intraosseous line, someone may be trying to push some adrenaline or epinephrine, somebody might be trying to help with the airway. And so I think we really need to focus on that at least 80%. You really want to minimize those interruptions. So if someone's trying to start an IV and they tell you to stop compression so they can start an IV, that might be necessary, but it's only for a second or two. Would you agree, Dr. Tut?
I agree. And you want to have that person who's doing chest compression be someone else who's not overwhelmed with task. So if you have at least 3 people in the room, the task of putting IV, the nurses, have that person not be the chest compressor. Another fifth point is avoid excessive ventilation. So if patients who do not have an advanced airway, like a ET tube, you want to do 30 to 2. So 30 compression to 2 ventilation in single rescuer. If you have 2 people, you want to do 15 compression to 2 breath. So every 30 compression to 1 breath. So 30 to 2, 15 to 2. Of patients who have an advanced airway, like ET tube or the LMA, upper airway, you want to give a breath every 6 seconds, but no pauses for compression. So hyperventilation, the reason hyperventilation is bad is hyperventilation leads to a higher intrathoracic pressure. So it leads to lower venous return and lower coronary perfusion. Another point is you want to make sure you have your hand placed properly. So in adult, the lower half of the sternum, and avoid the xiphoid process, and you want to use two hands approach. Make sure the compression and the hand placement and the technique is a smooth rhythmic compression. And 7 is if you've done chest compression, I'm sure most of us who are in this seminar have done it, your arms get very tired, and I get very fatigued. So you want to be cautious of those who are doing chest compression and switch out every 2 minutes. So meaning like every pause check, that 10-second time you're gonna use to check the rhythm and pause, gives your chest compressor a break. Switch it out.
Thank you so much. I think this is a really important time to mention non-technical skills in ACLS. This was not necessarily a question, but I think it's important to mention. And part of that is role clarity. So oftentimes you will have a leader of the code situation, and that leader is really responsible for keeping all of the big picture in mind and might be the one who tells the compressor it's time for someone else, and you've got, ideally like 2 compressors and allow them to switch and ensure that the compressions are not interrupted, ensure that the person who's managing the breaths or the airway is doing that at the correct rate, managing whoever's giving the medications, et cetera. So having role clarity and having at least one person who's leading the situation, the ACLS code situation, is really, really important to make sure that all of these happen at the right rate, at the right time, and in the right way. So I'm going to keep pushing on you, Dr. Tett. This next question I think is so important, not just for folks who work in resource limited settings, but for those of us who work in multiple different settings. You may be called to cardiac arrest and have to use a defibrillator, and they might be different than what you're used to seeing in other places. So the next question is, what is the difference between a biphasic and a monophasic defibrillator?
Let's take maybe 10 seconds for people to respond.
Perfect.
Okay. So I can see some audience member responding. So monophasic defibrillator send electrical current in one single direction from one pad to the other. So if you have front and back, so the electricity flows from one pad to the other pad, just one direction. And the shock consists of just one wave of current. But because of this single direction flow, higher energies are needed to successfully depolarize the heart muscle. So monophasic defibrillation typically deliver 360 joule for each shock, whether it is the first or second shock or any other shock. So it's 360 joule. So this is an older technology, but it is older technology. But it is less efficient and has a higher risk of causing myocardial injury as well as skin burns. So let's talk about biphasic. So biphasic defibrillations, on the other hand, deliver current in 2 phases. So if you have one pad in the front, one pad in the back, the current flows in one direction initially, so front to back, then reverses pathway partway through the shock. So front to back and then back to front. So this reversal helps polarize myocardial cells more uniformly and efficiently. Because of this, the biphasic defibrillations are able to achieve successful defibrillation at a lower energy level. So usually between 120 to 200 joules. So depending on the device and the waveform. So they have a higher first shock success rate. So and require fewer shocks and overall associated with less myocardial injury compared to monophasic shock. From a practical standpoint, biphasic defibrillators are now the standard of care. American Heart Association recommends you following the manufacturer's guideline for initial shock, usually around 120 to 200 joules. And if you only have a monophasic defibrillator, and then all shocks are delivered at 360 joule. And so that's why, like in modern clinical settings, biphasic defibrillators have replaced the monophasic ones.
Great. But you can still use a monophasic if it's the only thing you have.
That's correct.
Great. Thank you so much. Okay. What are some of the considerations for managing ACLS in low resource settings? I think you've done a great job, Dr. Tett, of talking about high quality CPR. That's probably the most important thing in the initial phases of resuscitation. Basic airway management, you talked about oxygen by nasal cannula or non-rebreather mask, or even just having a bag mask with high flow oxygen. You've talked about defibrillation and rhythm management. Specifically, you can use monopolar or bipolar defibrillators, which if you have a bipolar, that's preferable. Medications, we haven't really talked about that, but some of the more common medications, adrenaline, which we call epinephrine in our setting, is really important. What about access to give those medications? Dr. Tett, do you have any recommendations on how to get IV or IO, or what would you use first?
So the people have studied this, and I think whatever you can get quickest that's the goal. So if you have an IO and if you can establish an IO access, that's like often quicker in evidence-based medicine. And if you were able to establish an IV, and if you don't have an IO tool, IV is okay as well.
The next one says, remember to treat the H's and T's. And I really like this point quite a bit because not only are you looking for the cause or the etiology of why the patient went into cardiac arrest, but if you think about things in terms of H's and T's, you can also hopefully prevent cardiac arrest in a lot of situations. Can you tell us a little bit more about the H's and T's?
Yeah, so the H's stand for a couple of mnemonics. So hypoxia, hypovolemia. So if patients are hypovolemic from bleeding, hypoxia like pneumonia, respiratory failure. Another thing is electrolyte disturbance. So hypokalemia, hypomagnesemia. So those are part of the H's. And then T could be tension pneumothorax, tamponade. Someone commented in the chat about tamponade. So HT. So those are some of the example. And toxin is another one.
Yeah, I think about toxins. Yeah.
Yeah.
So if we treat those things early, I mean, I think in some settings I've seen that there's a lot of focus and excitement around ACLS and cardiac arrest, but ideally we would prevent it from even happening. So if you keep the H's and T's in mind and recognize that if they get too extreme, that it's a large risk of cardiac arrest. If we treat those things well, we can potentially avoid the need for ACLS. Did I miss anything when we talked about teamwork, roles, and communication? Was there anything else that you or Dr. Arkin or any of the other panelists thought about in regards to role clarity or communication?
I think oftentimes what I've seen in these situations is stressful. So I often recognize that it's stressful for nurses and other providers as well. So this is the time period to take ownership of dividing the role. Like people feel better if they have one test to follow. So like I often give like chest compressor. So like announce that person, you have to go with chest compressor, the nurse to establish medication. So division of roles help with communication and success.
Dr. Arkin, can I ask you, what do you teach when you tell people about closed loop communication? What does that mean to you?
Closed loop communication is a style of communicating in an emergency setting where, let's say, I'll say, Dr. Crawford, will you draw an ABG? And you say, Dr. Arkin, I'm drawing the ABG, running it now. And so not only is the request stated clearly directed to one person, ideally identified by name, that and then there's confirmation of receipt of the request and actual confirmation that the request is being performed. So I like loop communication. It's definitely the way that we're trained to communicate in emergency settings. I will say it's hard to do when the environment is chaotic. And so keeping the energy levels in control and kind of keeping the room in control is really important for making sure that commands and requests are not being missed.
Yeah, I think it's also confirmation that I heard what you said. So if you said, Dr. Crawford, draw the ABG, and I said, I'm going to sing my ABCs, then you'd be like, that's not what I said. So it also just confirms that whoever is on your team actually heard correctly the instructions, right?
Yes, that's correct.
Okay, yeah. Understand resources and system gaps for post-resuscitation care. I think before we go into post-resuscitation care, I want to mention a couple other things and see what the other panelists think. But I also think about two things in particular, simulation and practicing ACLS scenarios, and then also the use of cognitive aids. Can you share a little bit about your experience and what you think about simulating ACLS and what are cognitive aids and how are they used?
So I mentioned about how this might be a very stressful situation. So even though we remember HSNTs and learning in the medical school, in the panic, you can't think of it. So cognitive aid would be like things as simple as or like pamphlets that are attached to a card, or like your resuscitative card with the Zols monitor. So in the ideal situation, you can use that cards to refresh your mind about how much epinephrine to give in the cardiac arrest situation, how much amiodarone to give. So
How many
that's
how many joules to start with when you defibrillate?
that's correct. And how many joules for VTAC, how many joules for VFib, so those help with the stressful situation. Another thing is practice. So like you may have a new nurse who's never done this, and you may have a new tech. So like doing this in a system setting. So ideally, hospital, I should have ACLS, practice like every so often so that the whole team can get practice on how the coordination of care can happen.
Perfect. I think we're having a little too much fun and we're running behind on time. So, Dr. Tet, can you say maybe in one sentence the goal of targeted temperature management after return of spontaneous circulation? Okay, maybe like 3 or 4 sentences, but
Yeah, so the goal now is the current practice, avoid fever. You don't need to actively cool patients anymore. So a lot of literatures recently initially mentioned about cooling down to 33, but now just prevent fever. So which is perfect in the low resource setting. We don't need to go crazy. So often maintaining around 36 degree for 24 hours and avoiding fever for 3 full days. So that works in neuroprotection.
perfect. Thank you so much. So, no more making your patient hypothermic, just avoiding fever. Okay, Dr. Arkin, over to you. We're going to talk about time critical management of high blood pressure or hypertensive emergency. So, the first question is how much time is needed in hypertensive emergency to reduce the risk, and how much should the goal be to reduce the blood pressure? So, it sounds like this person isn't quite sure how to treat the hypertensive emergency, how quickly to treat the hypertensive emergency, and how low to drop the blood pressure when treating. So maybe you could help us out with this one.
All right. So I'll give folks another 10 seconds, but I already see a great answer in the chat. That is correct? We can go with that. So I see 25% in an hour. And so as we all know in medicine, everything is, a range. And so the idea so truly I think it's important to understand what do we mean when we say hypertensive emergency? We're talking about high blood pressure that's attributed to signs of end organ dysfunction. So that could be altered mental status, severe headache, AKI, chest pain, troponin leak, things that are telling you that the hypertension is causing end organ injury. And so really what you're looking for in that first hour is not to normalize the blood pressure. And when I say blood pressure, I'm talking about the mean arterial pressure, but really just to bring down the map such that you're getting control of the hypertension so as to not exacerbate this end organ injury. So typically, we consider that to be no more than a 25% reduction in that first hour. So an example of that would be, let's say someone's mean arterial pressure is 140, which would be very high. The aim would be to bring it down to a roughly 105, 110 of mean arterial pressure within that first hour. Going lower too quickly can lead to the opposite problem, which is hypoperfusion. And you may see things like altered mental status, decreased consciousness, things like that, and could even lead to coronary or renal ischemia. After this initial hour period, over the next several hours, blood pressure can be further reduced to kind of achieving our more typical blood pressure targets of a systolic less than 160, diastolic less than 110. And really, that just allows for gradual correction in terms of normalizing the blood pressure to something that you might be able to sustain over the longer term. However,
We're talking about hours to days in a hypertensive emergency. So in the first few hours, look at 25% reduction in MAP, but over the next 1 to 2 days, then we try to normalize it a bit further. What about these specific scenarios that are mentioned in the key points slide?
Yeah, so there are a few important exceptions when you just have to get the blood pressure down and you're willing to risk kind of that hypoperfusion because the reason for the hypertension is so dangerous. And so some important points include aortic dissection, where you have kind of a flap in an artery, namely the aorta, that can lead to kind of catastrophic hypoperfusion or even rupture. If that happens, you just get the blood pressure down. And so you're targeting impulse control. So you want to get the heart rate down, less than 60 beats per minute if possible. And then you also want to get the systolic blood pressure down to less than 120 as quickly as possible. Another example would be in severe preeclampsia or eclampsia, which is essentially seizure from preeclampsia. You want to get the blood pressure brought down to a systolic, again, less than 160 and diastolic in the 90 to 100 range within that first hour. And there you're really trying to mitigate the risk of intracerebral hemorrhage in the peripartum patient.
So similarly, patients with neurologic emergencies, such as bleeding into the head, you would also try to rapidly decrease that.
And I would say just in the comments, whether it's 30% or 25%, again, we're talking about kind of a range of control and a range of time. So you're kind of looking at about 25% blood pressure reduction within about the first hour in a hypertensive emergency. And you're looking for an immediate reduction for things like aortic dissection and preeclampsia within the first like 20 minutes or so. So while there's not going to be like a hard and fast cutoff, but we're talking about ranges for you to kind of target in terms of your clinical management.
One thing that always pops into my mind is risk versus benefit. So, is the benefit of reducing the blood pressure because the patient has a dissection or because the patient has intracerebral hemorrhage? the benefit of getting the blood pressure down is obvious, whereas the risk of hyperperfusion or ischemia may be less than the risk of those complications. So whenever you're looking at not only how to treat it, but how much to treat it, I'm always thinking about which is more risk or benefit in those decisions. You mentioned pre-eclampsia and eclampsia, so I'm going to skip through the question and maybe just jump to the key points if you don't mind, Dr. Arkin.
Yep, please. So,
Hypertension.
yes, hypertensive. So, as we know, in preeclampsia, you're really you have two patients, and so you have to be thinking about kind of what is the risk to the patient and what is the risk to the baby. And so this is considered to be a pretty high stakes scenario, and really your goals are to prevent maternal complications such as hemorrhagic stroke, heart failure, renal failure, progression to eclampsia, which is seizure, while preserving your uteroplacental perfusion and ensuring fetal well-being. So really not dropping the blood pressure so low that you're compromising placental perfusion. And so really your blood pressure targets, you're not targeting a low systolic blood pressure, you're really targeting a safe systolic blood pressure. And so you can see that the systolics you're targeting are going to be around the 140s to 150s. And we don't overly correct aggressively, but we do correct down to those systolics more aggressively. You'll notice that the systolic goals are lower than in kind of the regular hypertensive emergency. And that's because the nature of preeclampsia is such that it actually messes with and compromises the integrity of your blood vessels. And so lower blood pressure actually can still cause a hemorrhagic stroke. And so that's why we're targeting systolics of 140, whereas several slides ago, you saw that over time, we're targeting a systolic less than 160. Because in preeclampsia, these patients are higher risk of conversion to hemorrhagic stroke. We use labetalol, hydralazine, and nifedipine are the mainstays of acute management. Oftentimes PO if you're controlling over a longer period of time, but certainly reaching for your intravenous medications when you have an acute presentation. Magnesium sulfate is essential for stabilization of and prevention of seizure specifically. And so that's why we use it. It's neuroprotective against seizure. And delivery is really the only definitive cure for this state. And so delivering the baby as safely and quickly as possible while stabilizing the mom. And we mentioned kind of you have a two-patient situation. And so just always being aware of the fact that you're treating two people. Things that you may avoid are things like ACE inhibitors, ARBs, renin inhibitors are contraindicated because of risk of fetal issues. If this arises earlier during organogenesis during the pregnancy, it can lead to oligohydramnios and fetal death. And so we typically will avoid those medications. Nitroprusside we're often avoiding because of a risk of fetal cyanide toxicity. And so really leaning on those other three agents, the labetalol, hydralazine, and nifedipine.
Perfect. I might skip traumatic brain injury and move forward to intracerebral hemorrhage, if that's okay with you.
Yeah, especially one of the questions in the chat is really to talk about the distinction between ischemic and hemorrhagic strokes in terms of hypertensive emergency. So just to answer that question quickly. So when we're talking about hypertensive emergency, what we're worried about is a hemorrhagic stroke due to hypertension. What you can often see in ischemic strokes is you'll see kind of like a reflexive hypertension after the stroke. And so we try to lower the blood pressure a little bit after an ischemic stroke so we don't get hemorrhagic conversion. But ischemic strokes are typically due to a blockage in an artery in the brain or in the cerebral vasculature. And that can be patients who have hypertension are at higher risk of having ischemic strokes. but specifically the risk of stroke that we're talking about with these hypertensive emergencies is a conversion to hemorrhagic stroke.
Perfect.
So gold in managing hypertensive emergencies and intracerebral hemorrhage. So once you have intracerebral hemorrhage, really the blood pressure goal is to mitigate future damage. And the way we do that is lowering of the systolic blood pressure to less than 140. You typically within the first hour using IV agents. Oftentimes you'll see these patients are on drips of some kind to clofidobine, oftentimes calcium channel blockers. To try to decrease the systolic blood pressure and reduce hematoma expansion. You again, it's this balance. You don't want hypotension because you don't want to underperfuse the brain, especially when it's at risk. But when the cause is intracerebral bleeding, you really want to try to decrease the concern and the risk of expansion of that bleed.
Clofidopine is not really available in all locations. So some of the other titratable IV drips might be like nicardipine
Nicardipine,
is probably
exactly.
more. Labetalol is also, it's not a calcium channel blocker, but it also can lower blood pressure and it is IV titration as well as sodium nitroprusside and esmolol and nitroglycerin. So there are pros and cons to all of that. I don't think we have enough time to get into all the pros and cons, but the first line agents would probably be nicardipine or clofidopine if those are available.
Yes, kind of the non-dihydropyrimidine calcium channel blockers that are really that are not necessarily those negative inotropes that are going to kind of mess with your cardiac contractility, but are really specific to arterial vasodilation.
Right. Great. Thank you so much, Dr. Arkin. We're going to move on now to session 10, which covered oncologic emergencies. I think one of the really most challenging emergencies in oncology patients or cancer patients is tumor lysis syndrome. It really is a true emergency because it can lead to renal failure, cardiac dysrhythmia, seizures, and death, and that can happen fairly quickly. So I think we should maybe start with what is tumor lysis syndrome. It is essentially when you have a large number of tumor or cancer cells that lyse or break open and die. And during that process, you get release of some really pretty toxic things, such as potassium. You can get a hyperphosphatemia. You can get uric acid. And some of these substances that are released when the tumor cells lyse then lead to renal failure and arrhythmias. So how do you manage it? I think one is to recognize who is at risk for tumor lysis syndrome. There are a couple ways to stratify that risk. So you can look at the laboratory findings, such as potassium, or specifically potassium, uric acid, phosphate. And the other thing you can look at are the clinical complications. So do they have acute renal failure? Do they have cardiac dysrhythmias? So once you look at who's at risk for developing it, and then you know to monitor those patients' electrolytes and symptoms really closely, then you can start to talk about how to manage this really well, whether you have a lot of resources or don't have that many resources. So let's start with talking about the patients that are very high risk for developing tumor lysis syndrome. And these are really patients with lymphomas and leukemias that are high grade. So these patients often have a very, very high white blood cell count. And so when you have that really high white blood cell count and then you give them a chemotherapeutic agent, a lot of those cells will die and release these substances that can cause problems. The other patient population that's at high risk is if you have really a lot of bulky cancer disease. So you have widespread large amounts of cancer cells, even if it's a solid tumor. And then you're going to be predisposed to having problems if you have these high-grade lymphomas, leukemias, and bulky disease, if you already have underlying kidney disease. So intermediate risks patients or other other blood cancers, other hematologic malignancies, or smaller tumor burdens. And then the patients that don't have a large tumor burden are at very low risk. So once you recognize the patients that are at high risk for tumor lysis syndrome, you can start to take some corrective or preventative actions. And the first one, and probably the most important, especially if you don't have a lot of resources, is hydration. It's really the cornerstone of tumor lysis syndrome prevention and treatment. So even before you give these patients their chemotherapy, you want to make sure that they are very, very well hydrated. So a lot of us will try to use urine output, assuming they don't have underlying oliguria, but try to maintain urine output on the higher side. Some people will say 100 milliliters per metered square per hour. You can also, some people will recommend giving a certain amount of fluid per day. Obviously, anytime we talk about giving fluids and keeping people hydrated, you have to recognize those special patient populations where that might be problematic, such as someone with pulmonary edema, somebody with congestive heart failure, or somebody who already has a severe kidney injury who's not able to make urine. So if those things are absent, then really generous IV hydration or oral hydration, if able, prior to giving the chemotherapeutic agent will really help kind of flush a lot of those toxins out, utilize the kidneys. You may actually have to give a diuretic, assuming the patient has had a lot of fluids. And then the next thing is really the control of the uric acid that is released, or hyperuricemia. The uric acid can form crystals within the renal tubules, which can cause additional renal injury and then therefore renal failure. It's really two main agents that we think about when we manage hyperuricemia. The one that's going to be most commonly available, and perhaps even in most resource-constrained settings, is going to be allopurinol. So allopurinol is good because it prevents the further formation of new uric acid and uric acid crystals, but it doesn't do a lot for the uric acid that's already there. So the agent that we would use ideally to decrease the amount of uric acid that's already there is called rasburicase. And rasburicase essentially converts uric acid into a more soluble compound called allotonin. So if you have allopurinol, continue to give that even if you don't have rasburicase, and you will see a reduction in your uric acid, albeit much more slow than if you were to give rasburicase. Again, keep those patients really, really well hydrated. The other big problem we talked about is hyperkalemia and hyperphosphatemia. So hyperkalemia can certainly be an emergency. We all recognize that. So giving the typical hyperkalemia treatments, hydration's already in place. You want to give your insulin and glucose. You want to give your beta agonist to switch the potassium back into the cells. And then if you can make sure they're hydrated, and give a loop diuretic to actually get rid of the potassium. And then if the patient is acidotic, then you might want to consider a bicarbonate agent, or even just to push the potassium back into the cells. The other common electrolyte abnormality is hyperphosphatemia. So you may or may not have access to phosphate binders, but those can certainly be used. You want to restrict dietary intake of phosphate. And then the last electrolyte disorder that we think about is hypocalcemia. Unless the patient is really symptomatic from low calcium, we tend not to replete it. So symptoms of very low calcium would be like tetany or seizures or dysrhythmias. And in those situations, we would consider replacing calcium. The reason we don't do it otherwise is because it can lead to calcium phosphate precipitation or crystals in the kidneys again. So it would be a second or third or fourth reason for the patient to go into renal failure. So in summary, for tumor lysis syndrome, the most important thing is recognizing who's at risk for tumor lysis syndrome, ensuring that you prehydrate these patients really, really well, and use allopurinol even as a prophylaxis, or rasburicase if indicated. And then once you give the chemotherapeutic agents, really monitoring closely the potassium, the phosphate, the uric acid. If you have fatal arrhythmias or seizures, then you really need to take more aggressive care. Did I miss anything from my other panelists that you guys think about when you're treating tumor lysis syndrome? Dr. Arkin or Dr. Tett?
I
No.
think you covered it all.
Mhm.
Good. Thank you. I'm glad I did an okay job. Um, so this is a great question. We talked a little bit about ways to manage tumor lysis syndrome if you don't have all the resources available, but in general, how do we manage oncologic emergencies when we don't have all the resources available to us? And so I think the general principles for this answer would be recognizing what are oncologic emergencies. So we talked about tumor lysis syndrome, but also recognizing that if you have a solid tumor on the spinal cord and the spinal cord is compressed, that is an emergency. Sometimes people develop what's called superior vena cava syndrome. That is an emergency. And then the other more common oncologic emergency is neutropenic fever or neutropenic sepsis. So just being able to recognize that those are emergencies and recognize them early is really the biggest thing that we can do when we don't have all the resources available. So clinical vigilance is the summary there, and we need to be able to recognize the red flags. So with tumor lysis syndrome, not only do you recognize who's at risk, but then if you start to see those lab values or some of those clinical symptoms, recognizing that we need to increase our management. And if available to us, we should triage the patient or transfer the patient to a center that is better capable of caring for those things. I think widely available interventions are going to be our fluids and hydration. If it's a spinal cord compression or someone is in shock, you can consider steroids. Basic electrolyte management will prevent those fatal arrhythmias. If you have a neutropenic fever patient, giving broad spectrum antibiotics and managing them so they don't go into shock are also key elements of managing any patient. And then recognizing that we do need multidisciplinary teams. So even if you don't have an oncologist at your center, call one on the phone. Call your referral centers. And even if you don't have, the labs or the diagnostic investigations, ask to transfer that patient out. Any other considerations from the panelists? Oh, you can use steroids in superior vena cava syndrome as well. So these things are widely available: fluids, steroids, antibiotics. It's really that essential emergency and critical care that can be offered to these patients until you can get them to a higher level of care. Okay, so in summary, managing oncologic emergencies hinges on early clinical recognition, low-cost interventions such as fluids, steroids, antibiotics, prioritizing stabilization while arranging referral. And I would say here also consider calling a friend, texting us on WhatsApp, whatever needs to happen when you have questions about these kinds of patients. And then just everything has to be done earlier, because once the patient really gets into trouble and really gets critical, it can be more challenging. Okay, one of the other learner questions, which I thought was also good, and it's more a question about health systems. It's more a question about policies, processes, guidelines, checklists. So how do I best equip my unit to respond to oncologic emergencies? So whether you're in an intensive care unit, whether you're in an emergency department or on the general ward, you really have to recognize things early. So having systems in place where the whole team is trained to recognize a decompensating patient, and then having protocols for rapid response. So early recognition, rapid response allows the key interventions that can reverse that critical condition. And then also, if you're in a district hospital or a rural hospital, thinking early about referral and triage to a higher level of care if possible. So training staff, we talked about simulations, we talked about cognitive aids. So helping people not only recognize these critically ill situations or critical conditions, but also giving them that first step of how to intervene and escalate care. There's a vital signs directed therapy is a really good one. We have other early warning scores and for clinical situations. Another thing that can be done to make units, whether it's an ICU unit or a ward or an emergency room or a recovery room after surgery, more responsive, is to make sure you have kit. Make sure you have a cart that has essential supplies and medications. So whether this is a code cart or if you're, for some reason working in a center that has a high level of cancer patients, making sure you have those very standard, commonly used medications such as antibiotics, steroids, maybe allopurinol, things like that. Fluids, protocols, referral and escalation pathways, education simulation. I think those are the main things. So it's training your staff, stocking your equipment, establishing pathways and protocols, simulating, and then clear referral networks. Any other thoughts that came from the other panelists on how to, from a systems and workflows lens, how to improve the care of oncologic emergencies? Anything else come to mind? I guess that's a no. All right, so we will move on to session 11, maternal hemorrhage. Is Dr. Kimani here with us?
No.
She said she was going to join. Okay, well, we'll just go ahead and proceed with the first question on maternal hemorrhage. So, Dr. Tett and Dr. Arkin, you can help me out on this one. What are the major causes and risk factors for maternal hemorrhages?
Do we give folks like 10 seconds to answer?
Absolutely, yes.
Yep, definitely hypertension, gestational preeclampsia.
Dr. Kimani's here. She can't unmute, she says. Can you make her a co-host? Rachel Kimani.
Okay.
Apologies for that.
Okay, thank you.
Yeah.
I was trying to unmute, then I guess the rights had been limited.
No problem. Thank you so much.
Yeah, so I'm seeing guys answering the question. So what are the major causes of risk factors in maternal hemorrhage? We all know that the commonest that can happen is usually the uterine atony, and then we have the pathologies that happen with the placental pathologies, whereby you could have either placenta previa, placenta abruptio, which placenta abruptio can be very detrimental and can also lead to the death of the patient due to excessive blood loss. But we usually frame these causes based on the 40s, if you all remember. There is the torn tissue, trauma, and thrombin, whereby now if it's torn, you're thinking about the uterine atony. The tissues would be the placenta, could be trauma, and could also be coagulation problems. I'm saying guys have answered. Is there anything else that I've missed? Yeah, and also multiparity. Good stuff.
Okay, we'll go to the summary slide and make sure we didn't miss anything. So it looks like 4T's, great.
Yeah, the 40s, so torn tissue, trauma, thrombin. And then we also need to think about what are the risk factors. Is this a patient who has had a previous history of obstetric history of prior PPH? Somehow, when you have previous history of PPH, you could end up having now severe PPH in your other pregnancy. Also having a history of cesarean section is also a risk factor. We have the pregnancy factors where we are looking at the multiple gestation. Multiparity also causes a risk factor to all this. You have intrapartum factors like prolonged labor. When you have prolonged labor, because maybe during that labor process, they have given you uterotonics like syntocinon. So at some point, the receptors are all occupied and there's no sensitivity to the drug. So that lack of sensitivity leads to the uterine atony, and eventually the patient can end up having severe hemorrhage. And it's always important to have a high risk of index of suspicion when you're managing, sorry, when you're
Perfect.
managing these patients. So you always want to prevent and have all the maneuvers ready, or even just suspect that this will happen so that you know what to do.
You also mentioned preparedness and team training, and this has been an answer to almost every question that we've had today. So anytime you have something that is time critical or critical care or emergent, preparing for it ahead of time with your team, training your team, making sure you have the kit, all the supplies, making sure you have a cognitive aid. Those are always answers to making sure we do take a good care of our patients when they're in a critical situation. I like this question a lot because oftentimes we don't have an ICU or we don't have someone trained in critical care. And oftentimes, even if we're a medical officer or a nurse, we are forced to take care of patients that make us feel nervous because we don't have necessarily all the equipment or training or team support. So, Dr. Kimani, I think this question is really great. It's obviously very personal to some of our learners. So, if I'm an internist with less exposure, how do I know to call for MTP support, and what is MTP?
Is anyone, do I give them a minute to answer?
We're actually running out of time. So all of the answers are on the Learning Resource Center, and these slides and notes have been updated. So I'm wondering if we could maybe just move ahead.
Okay.
Okay.
So when you suspect that you're going to have an adverse event, you need to immediately have your call support. Think of who to call. Think of escalating into the next level of the next person, the next senior person in the unit. It could be the obstetrician, it could be the anesthesiologist, it could be senior registrars that are in your unit, because you need to always have these red flags and know that you need to worry, especially when you're having excessive hemorrhage in this type of patients. So always have a high index, and also knowing what amount of blood loss what's your allowable blood loss? At what point should you think that now you're going to have severe hemorrhage? Anything, when you start having blood loss more than 500 mLs, especially in vaginal birth, and more than 1 liter in cesarean, and the patient is still bleeding, it shows that it's time that you need to escalate. The other thing, you also need to look at your hemodynamics. How are they? Are you having a tachycardia? Is the patient hypotensive? Is there deranged mental support? Is deranged mental status? So at that point is now you escalate to the next. So don't wait for hypotension to happen so that you can communicate early and act immediately.
Perfect. Thank you so much. And just recognize, I think we started the conversation with recognizing which patients are at high risk. And so if you already know these patients are at high risk, then you should already think that it's a possibility. So I think I'm trained as an anesthesiologist in addition to being an intensivist. And I think maybe Dr. Arkin and Dr. Kimani, when you were in anesthesia training, I was taught always plan for the worst case scenario. And maybe it's similar in emergency medicine training. I'm not sure, Dr. Tet, but always imagine the worst thing is going to happen and prepare for it, and then you'll be ready. Is that the same for you?
Yes,
Yeah,
it is.
same
You
for
have to
me
think
too.
of the worst.
Yeah.
You always have to
Especially
think of
with
the worst.
maternal hemorrhage, where it can be so fast.
So
And
fast.
so you just have to act so fast, and it's associated with so many kind of atypical coagulopathies like hypofibrinogenemia. So you just have to always be thinking ahead, particularly in this clinical scenario.
So the initial question, so that reminds me, the initial question is, I'm an internist with less exposure to these cases. At what point do I worry or call for massive transfusion protocol to support the management? Sometimes maybe as soon as you have this patient who is bleeding, so maybe immediately, and even if you don't pull the trigger for massive transfusion, you can call your blood bank and say, I have a patient that is at risk. Please be on standby in case we need to activate MTP. Would you say that that's something you would think about?
Yeah,
Oh,
and
yeah.
even to be a little even more concrete, like for vaginal deliveries, if the OB is telling you that they've had more than 500 cc's of blood loss, that's the time to think about maternal hemorrhage. And then for a C-section, more than 750 cc's of blood loss, that's the time to think about. Yeah, I think it may even be less than that. It might be 250 for vaginal, excuse me, and 500 for C-section. And once you kind of hit those numbers, you need to be thinking about maternal hemorrhage.
Great.
And also, in addition to that, we also need to factor in maybe this patient started with a lower HB. So we might not have to wait for that 500. If you're looking at the hemodynamics and you're seeing there's a hemodynamic derangement and instability, you immediately activate this MTP response.
Yeah. Yeah. Bleeding kills obstetric patients very quickly, very quickly. Okay. So knowing that it is very high risk and deadly sometimes in our obstetric patients, what happens when faith or culture get in the way of life-saving blood transfusion and obstetrics hemorrhage? Dr. Kimani, I'm going to let you take this answer.
Especially in our setup, at times you may have cultural things or faith, like for example, the Jehovah Witnesses. You can have some of those Jehovah Witness patients coming with the cards that usually tell them they're not going to accept any blood products, any human blood products. So we also need to be very keen with such patients and explain to them what it means when they lose too much blood, that it can lead to death. But if they insist that their cultural values supersede your medical decision, then you just have to look for other ways. You have to try and supplement. It doesn't have to be with the blood products. You can do the fluids, or you can do other interventions to at least try and save the patient and try and manage the situation. Because if they're not going to accept the blood, or their culture does not allow them for accepting blood, then you just have to respect that and offer the service that the patient is comfortable with receiving.
I think one thing that comes to my mind with that is it's not just the mother's life, and it's also the child or the baby. So maybe having a conversation around that, because sometimes people do change their minds. So if you were to say it could risk your life, but also the life of your child, are you still adamant to not receive blood? And then sometimes, yeah, using the colloids, using fluids, those types of things can also. Sometimes people will accept albumin and sometimes they won't. So it's also very individual, these questions, wouldn't you say?
Yes, yes, it's important to have both factors and offer the best possible support that you can offer to these patients. So you also it's important to also respect the patient's decision in such tough situations.
Yeah. Okay, so communication, respect for the patient's own personal decisions or autonomy. Good communication. Maybe they don't fully understand the risk. We talked about alternatives. TXA is tranexamic acid. Do you have that in your setting, Dr. Kimiani? Do you use that in these situations?
Yes. We actually, it's recommended that we use it in all these situations. So it's not a problem.
Perfect. What about cell salvage, cell saver, things like that?
It's not a common thing, but especially in the government and the lower facilities, you don't have the cell salvage, but we can also, there are ways that you can do now the autotransfusion, which is available, but cell salvage is not a common thing. It's quite an expensive tool here.
Certainly. Any other thoughts about this culture and ethics question? Even in the chat from the learners, we can discuss.
I think ethics is very difficult in these, high emotionally invested situations with lots of conflicting, opinions.
Yes.
Yeah, it's just very difficult.
I think it's a challenge even within your own setting and your own culture. But when we start to talk about from a global perspective, and we have many different cultures and religions and contexts in which to think about these things, it becomes even more challenging and nuanced, in fact. Were there any questions in the Q&A that we did not get to? I want to review those. I think we're already over time, but how do you how do you diagnose mismatched blood transfusion, and how do I manage it in emergency situations? There's lots of different types of mismatch and transfusion reaction. You can have anything from simple fever to actual incompatibility from the blood typing. So one is to go back and look at the blood typing and see if that was done correctly or not. But in the worst case scenario with the transfusion reaction, you have a patient who this has happened to me actually. The patient immediately felt a sense of doom and felt really, really terrible, and then went into renal failure. And so you have to manage that. You stop the transfusion is the first thing you do, and then good IV hydration and supporting renal function and blood support are the other things. The slides are on the Learning Resource Center. Every single time we put all of this onto the LRC. So go to the Learning Resource Center to find the slides, the notes. Everything is free. Everything is downloadable. I want to just take, and I'll pop that in the chat here in just a second. I would just want to take an opportunity to, one, thank all of these amazing panelists for today's session. Thank you, Dr. Ted, Dr. Arkin. Thank you, Rachel Kimani. Unfortunately, Danielle could not make it with us today. But I also want to thank all of you, the learners. This has been an absolutely amazing experience for me as the coordinator of the Foundations in Critical Care session. It's been unbelievable for all of the panelists from all over the globe that have worked together to deliver this series. This is our final series, and it's a real honor to have all of this community of learning together, where we're all learning so much from each other, especially with different resources, different cultures, and all of those things. So I just want to say thank you to all of you, the learners. This is definitely makes my heart very happy to be with you and working together to take better care of our critically ill patients. So thank you, thank you, thank you. Again, for your certificate and CPD, you will automatically receive an email. And yeah, and this is the end of our series. So thank you so much to everyone. And we'll see you again sometime. At some point, I will find another grant and some more money to support these efforts and to support all of you in your clinical endeavors. So thank you so much for everything and for always working to take care of patients. Bye. See you next time.